CME Info's continuing education and board certification programs bring the conference to you. The following is a video sample from the University of Pittsburgh School of Medicine. This excerpt is from Dr. Teresa A. Gelzinas' lecture titled Cardiovascular Anesthesia.
The best monitor is actually the echo. And how echo works is an ultrasound beam travels through tissue. This beam is reflected back to the transducer. The sound waves then are converted to electrical current, and this current is converted to an image, which is projected on the monitor. Indications include to determine the presence of any valvular disease, to look at left and right ventricular function, and to look for ischemia, which manifests as regional wall motion abnormalities, to look for intracardiac shunts, such as atrial ventricular septal defects, to evaluate the aorta for atherosclerotic vascular disease, aneurysm, trauma, or dissection, to evaluate the pericardium for tamponade, and to look for pulmonary emboli or fat emboli in either orthopedic cases or liver cases. Intraoperative uses include to evaluate ventricular function, fluid status, ischemia monitoring, valvular function, to look for intracardiac air if you're doing intracardiac procedures such as valvular procedures, aortic atherosclerotic disease, which can change an on-pump case to an off-pump case, pulmonary embolism, and in trauma, you're looking for the presence of cardiac problems such as valvular disruptions, aortic transections, or pulmonary emboli. Contraindications include patient refusal, severe gastroesophageal disease and coagulopathy, and complications include oropharyngeal trauma, gastroesophageal trauma, and dysrhythmias. So, this is the most common mid-esophageal view. This is the mid-esophageal four-chamber view, and the top of the screen is always the left atrium in the mid-esophageal view. So this is the left atrium, the mitral valve, the lateral and septal walls of the left ventricle, the interatrial septum, the right atrium, the tricuspid valve, and the RV. This is the most common view, period. This is called the donut view. You all ate breakfast, right? So you're not hungry. So when you're looking at this, the probe is actually here. So this is the inferior wall, the anterior wall, the lateral wall, the septal wall, the anterior septal, and the inferior lateral wall. If you look in here, fluid is black. So if you see the walls touching, you know the patient's hypovolemic. If you can see they're moving in and out, if they don't move in and out, then you can actually see that there's a regional wall motion abnormality. So inducing a patient with ischemic heart disease, the goals are to optimize oxygen supply and demand. Now, myocardial oxygen supply is dependent on three factors. The first is the arterial oxygen content, which is just the oxygen attached to hemoglobin, which can be calculated as 1.34 times the hemoglobin times the saturation, added to the oxygen in the blood, which is the arterial oxygenation times the solubility factor of 0.003. Then the cardiac output, because you need to get the oxygen to the body, and the coronary blood flow to get the oxygen to the heart. Myocardial demand, the biggest determinant is heart rate, followed by contractility, wall stress, preload, and afterload. So our goal is to increase myocardial oxygen supply. One is to increase oxygenation, and we all pre-oxygenate our patients, right? Then to optimize hemoglobin concentration. Then the last is to optimize coronary blood flow. And coronary blood flow is dependent on coronary perfusion pressure, which is the difference between the aortic diastolic and the LVEDP, the heart rate, the coronary vascular tone, and the presence of atherosclerotic plaques, which we can't do too much about. The other goal is to decrease demand. So you want to keep the heart small so you can decrease wall stress. You want to slow heart rate. So that will decrease demand and also increase supply because it'll give the coronaries more time to perfuse. You also want to maintain blood pressure. If it's too low, you do not perfuse your coronaries. If it's too high, you increase your afterload. It's also important to maintain sinus rhythm for optimal filling of the left ventricle, and if you have a hyperdynamic heart, you would want to decrease contractility. There are two ways you can put a cardiac patient to sleep, either a high-dose opioid versus a volatile agent or IV induction. It depends on the time to extubation, the patient's ejection fraction, and other comorbidities. The advantages of a high-dose opioid induction: there's no myocardial depression, you have a decrease in heart rate, and it's useful in patients with low ejection fractions. The disadvantages: there's no amnesia, it can produce hypotension with other sedative hypnotics, you have a longer extubation time, and it's hard to titrate. The advantages of volatile anesthetic induction and maintenance: it's easy to titrate, you have myocardial depression, which may be useful in patients with hyperdynamic hearts, you suppress the stress response, you provide amnesia, you can have coronary artery vasodilation with greater than 1 Mac of isoflurane, and because of potassium receptors, there's also ischemic preconditioning, so you can protect the heart against further ischemic episodes. The disadvantages: there's hypotension, myocardial depression is bad if you have a low EF, you can have epinephrine release with desflurane, and there's no postoperative analgesia. Again, it's used if you want to extubate your patient early or if you have a hypertensive patient with preserved ejection fraction.
Top quality board certification reviews and continuing education programs, guaranteed. For more information about this self-study activity, go to www.cmeinfo.com/773V or call us at 1-800-284-8433.